Dr. Suzanne Jondeber is Associate Professor of Medicine at the Johns Hopkins University School of Medicine and Associate Director of the Clinical Research Units of the Johns Hopkins Institute for Clinical and Translational Research. She received her BA and her MD degree from Cornell University. She completed the Osler Medical Residency at the Johns Hopkins Hospital and her fellowship in endocrinology and metabolism at the Johns Hopkins University School of Medicine. As a physician scientist and a practicing endocrinologist, her clinical and research work focus on understanding metabolic bone diseases at the basic level and translating these observations to the bedside. Specifically, her research interests include understanding the physiology of FGF23 and the molecular basis of disorders of phosphate homeostasis emerging treatments for rare bone diseases, and the genetic basis of parathyroid hormone-resistant syndromes. In addition, she is actively engaged in shaping clinical practice to improve the diagnosis and treatment of osteoporosis. She contributed to the National Osteoporosis Foundation's guidelines for the prevention and treatment of osteoporosis. Dr. Jondeber is a member of the Endocrine Society and the American Society of Bone and Mineral Research. Dr. Jondeber has served in a number of leadership roles, including counselor, chair of the Membership Development Committee, co-chair of the 2011 ASBMR annual meeting, and the chair of the Professional Practice Committee of the American Society of Bone and Mineral Research and president of Advances in Mineral Metabolism. She has served as associate editor for the primer on metabolic bone disease and disorders of mineral metabolism. Dr. Jondeber has authored numerous peer-reviewed publications, reviews, and book chapters in high-impact journals, including New England Journal of Medicine, Journal of the American Medical Association, Journal of the Clinical Investigation, and The Lancet. Please help me welcome Dr. Jondeber.
I want to introduce my partner in crime here, Joanne Joseph, who's well known to all of you for her long involvement in the XLH network. So what we're going to do here to try to give an adult perspective on XLH is I'm going to do a little interview with Joanne, and then we're going to pepper a little bit of information in between. Because Joanne's been riding this road for a long while. So this is going to be a story about traveling the road together. So I'm going to start out by, you've heard an introduction about me way too long, unfortunately. Sorry about that. But I just want Joanne to give a little quick introduction to who she is, and then we're going to move through kind of her journey as an adult with XLH with specific questions.
I have XLH, and I have two children. I have a daughter and a son. My daughter has XLH. My son does not. My daughter has two children. They have XLH. So, I mean, it's there. I have 5 grandchildren. And my son's children do not have XLH. The day I met Joan Reed, I was really thrilled because I knew that we were going to be able to do something and that this would fly and it would be great. I don't see her here now, but...
No, she's back in the back. So you're talking about your work with the XLH
So Joan
network.
and I decided we would start this. We didn't know that it was going to be a nonprofit right away. I couldn't have done this without Joan, really. It has really grown, and it's wonderful. I think it's a great thing, and this is what we wanted. We wanted, an organization that was for people with XLH.
What years were that, Joanne? What years were you working with the XLH network?
I don't really know. I think it was somewhere around, is Joan here? Maybe
Yeah, Joan.
Yeah, I was going to say maybe 2002, and it was before we incorporated. It didn't take long before we felt we knew we wanted to do this. And as I say, I was glad that Joan and I met because it would never have happened, I don't think, without Joan.
What type of issues were you working on then in 2002, 2003, 2004? So you were getting grouped together to try to raise awareness.
Yes.
And was there? I remember you used to meet with several of us at the bone meetings to try to get the clinicians together to try to work to move forward research and patient care in XLH.
That was the easier part, working with the clinicians. It was difficult, but with the clinicians it was great, and we were very happy. It's been a great help, and it's. was wonderful to have them involved in the network.
Well, we're grateful to your work, to Joan's work, to Lane Jacobson, and all the kind of pioneers in the XLH network. And it's really exciting to see how it's grown, and it's wonderful to have Elizabeth bringing everyone together for XLH Day. So it's really an honor for me to be part of this, and I really am excited that you thought about it and dedicated your effort to it. So now we'll talk a little bit about you. So my question for you is, Joanne, the road to your diagnosis and getting on the right treatment was a long one. Can you tell us about that journey, like from the time you were a little child?
Okay. I was born in New York. I was born in Brooklyn, New York. And I guess I was about maybe only a year old. My mother knew something was wrong. So she started her path to doctors, to pediatricians, and they sent her. And eventually there was, at the time, a good hospital in Brooklyn, which was the Methodist Hospital of Brooklyn. That's where I had my first surgery. My first of 12 surgeries was there. And then after I had that surgery and I was walking around, my mother could see that it's not working. And she had a doctor friend there, and the doctor friend said, well, you got to go to a research center. So he sent us up to Columbia Presbyterian. And I spent 12 years at Columbia Presbyterian. And I had a lot of surgery there, and I had very good doctors. I think I had too many surgeries, because I can now see that if you have too many surgeries, I don't think it's good. I don't think it's good for the bones. But what do I know? I'm not a doctor.
Joanne, what struck me when we were talking about your story was that initially your mom was told, oh, that's just normal bowing.
Yes.
And then you moved to California for a year, and then you moved back to the
My father
New York
was an
area.
engineer, and we all went and headed out because he had this particular job he had to do. And my mother did know that there was still something wrong, but she figured that. So we went to California, we came back. I had grandparents there, so we stayed there for about maybe a year, and then we came back. And when we came back, she went back to the pediatrician, and she said, this is not working. And so the pediatrician told her, well, if you would get her in the sun and give her some castor oil, this might help. And it didn't, surprisingly. But once we got into Columbia Presbyterian, they seemed to really start to go at it. Even though there was a lot of surgery, but I can't remember what they had me on. They might have had me on Drisdol shortly after I got there.
I think that's what you told me, yeah.
But they were very big with braces and body casts and surgery. But it's a big research center, so what do you think you're going to get? Eventually, it worked out. We got a better doctor. We got a doctor up at Columbia Presbyterian, and was my doctor for years, and he treated me, and my legs did straighten out somewhat. But I then still had osteotomies when I, as much as like maybe 7 years ago.
And correct me if I'm wrong, but I think you told me too that it was really not until you're about 13 years old that you actually had the diagnosis of X-linked hypophosphatemia.
Yeah, and the medication. They didn't get the medication straight at first, and then they had me on what was called Drisdol, which was an activated vitamin D, but I wasn't on phosphorus. And then they got me on a liquid phosphorus, which was gagging, and that was a fight every day. When I started getting into the phosphorus and the Drisdol, my legs were straightening out.
And I remember you too saying that you had multiple surgeries, but there was failure of healing. And this were surgeries before you were age 13. So all this was happening, and they didn't have you on the phosphorus.
Right.
I was also intrigued, just from a medical professional standpoint, the perception as a child of basically being the kid with a rare disorder and what that felt like. Can you talk a little bit about that?
Well, I tried to keep up with everybody else, and I had a brother and a sister older than me. Yeah, it was difficult, and it was difficult in school. You live with it.
What about with the doctors when you were with the medical students and the residents?
Well, that's when you go to a research center. They would have me up on a podium, sort of like, and I would be marching around with a little skimpy, they used to call them. I can't remember what they called them. And I was a little kid. This was like very hard for me, but they wanted me to expose my legs so that they could see the bowing really. You can't see it if you've got a lot of clothes on. And that was really hard for me. And I knew when I was in the hospital, if they were taking me somewhere, where are we going? I said, where are we going? And they wouldn't answer me. You'll see. And it was awful, because it'd be a room like this, and I'd be, walking on a stage. It was like a stage.
That's tough,
That's something
yeah.
I guess you have to put up with when you're in the research centers. But I guess it helped, and it worked out well. I mean, I really don't have a lot of pain. I feel good. Something worked.
Yeah, absolutely. Let's talk a little bit about your children and your grandchildren and your great-grandchildren. So you talked a little bit that you have a daughter with XLH
Right.
and a son that doesn't have XLH.
Yes, my son does not have XLH, but my daughter does. And so, but I knew what to do. I mean, I took her to the right doctors. I went back to Columbia Presbyterian. It was the same story over, but she did not have a lot of surgery. I think she's only had one surgery, actually.
And then your daughter has 3 children?
She has 2 children, and she has a boy who has XLH, and he has a really serious case of it. He's got the hearing problems, he's got stature, he's only 5'2", and he's bow-legged, and so he's got a lot of problems. But he goes to regular school, he's extremely smart, he's good in physics, he wants to be a physicist, but some think people have it worse. My daughter might have had it worse, I don't know. But see, I knew to take care of it right away, but everything I did for her, we did for him, and it's not working. And he's going to a pretty good doctor. I mean, it's out at Stony Brook University, but we wish we could do more. And my daughter, her daughter has it. She had a daughter and a son. The daughter has it, but the daughter has a very mild case, it looks like. She's never taken the vitamin D. Her legs are slightly bowed, but not much at all. I mean, she's probably as bow-legged as Jackie Kennedy was.
So it sounds like there's some variability of the presentation of XLH in your family.
Right.
And I just wanted to review this. I know that everyone in here knows this, but I think a lot of doctors don't know this. So whenever we teach medical students or medical professionals, in fact, Dr. Carpenter and I were just at the American Society of Bone and Mineral Research talking to bone experts about this, but XLH is an X-linked dominant disorder. And so many times you may get wrong information because most X-linked disorders are X-linked recessive. So that means that boys usually are the ones that get the disorder, but girls don't get the disorder. So sometimes people get misinformation saying, look, your daughter won't have this, but your son will have this. But this is not true in an X-linked dominant disorder. X-linked dominant means you just need one copy of the disturbed PEX gene to have the disorder. For example, in Joanne's family, 50% of her children have XLH. Her son inherited her X that had the problem with the PEX gene, her daughter inherited the X that had the problem with the PEX gene, and her son inherited the X that didn't have the problem with the PEX gene. And then you see this in her daughter. Her daughter gives one of her X to her son, and then another of her X that doesn't have the problem to her daughter. So in females, it's about 50-50, and then in males, 100% of daughters will have XLH, and 50% of the sons. So it's important to understand that it's X-linked dominant and not X-linked recessive, so people get aberrant information if they don't understand that. Okay, Joanne. So what are the challenges of raising kids with XLH? When you were
That
raising
was
your...
hard. I mean, my son did not have it, and he was very athletic. He's about 6 foot now, 6'1". My daughter, she was very easy, and she did the piano. She did do ballet, which was very good for her, I think, because she built muscles in her legs. But it was hard.
What about getting them to take medicine?
Well, that wasn't as bad as what I had, because all they had to do was swallow a pill.
It wasn't as bad as the liquid, which was
No,
really
you have to drink
awful.
it. So I didn't really have that much of a problem with my daughter.
She told me, too, that she had to wear braces. Were those
did.
on her legs? Was that where
She
that...
had everything. She had braces, and yeah, she did. She had braces. She had one surgery. That's all, really, but the braces were difficult and heavy.
Yeah, she said that
put
you locked
braces
heads
on a
trying to get her...
two-year-old. A 2-year-old, the braces, it's like she didn't want it, but she was good about it. She did do it.
Yeah, I know it's tough giving kids medicine 4 times a day and getting them to wear their braces, and it's
Right.
just another extra added
That's right.
issue in life, yeah. So did you stop treatment when you finished growing?
Yeah, for a while I did, and then I went back to it.
And when did you?
Because you have to go back to the doctor that knows about it. I mean, it's hard to find.
Yeah.
It really is. And I'm even having a problem now when I tell doctors, you know, they get that look in their eye, this classic look. That really say, I have a rare disease, I have a rare disease. And when they hear that it's vitamin D related, they're like, okay, well, you can make an appointment. But really, they don't really want to get involved with it. Because, you know, and a lot of them, if you're there for a different reason, they wonder how it's going to be to protect. You know, if you go in there for another reason and not for because of your bones or whatever, they still get a little nervous about, well, how am I going to treat this when she's got this rare disease, you know? So it's still not all that easy.
I agree with you. When you stopped treatment and then restarted, do you remember how old you were when you restarted?
I was probably about 18, maybe 17.
Okay. And how were your 20s and 30s when you had?
They were fine.
They fine?
Yeah.
Any issues at all? Any problems with your teeth? Any problems with
Well, I have
fractures?
problems with my teeth like everybody with XLH. I have probably thousands and thousands of dollars worth of work in my mouth. But that's something you have to live with. And that's hard with children, to get them to floss their teeth and brush their teeth, and you have to get them to understand that this is going to affect your teeth. It's very hard with kids because, you know, if they're walking around, they think they're fine.
Did you have any issues with the dentist being hard on your kids about their teeth, like accusing them of not brushing and flossing?
Well, that's another thing. You go to the dentist and you tell them if they have this vitamin D, and they're like, oh, God. And so, I mean, you do, and they, you know, they do the best they can. Now, I have a problem with my dentist because we like each other. But
You built them a new house.
has
Of course they like
such
you.
a hard time in my mouth because my jaw is tight. And it's very hard to get into the jaw and to get working in there. And they have to leave more time for me than any other patient.
It's interesting. So the 20s and 30s were pretty good, some dental problems, but really nothing else.
No.
Things changed in your 40s and 50s.
Well, yeah, in my 40s and 50s, I started to have pain, and I didn't always have a lot of pain. I had pain. So, of course, you know, if I go to an orthopedic doctor, I did have to have surgeries. It was hard because all of a sudden you have pain, and luckily I didn't have a lot of pain earlier. I only had pain after my surgeries.
And you said your first problem was in your 40s. You were had just played tennis, but then you were shopping in the mall.
I had my tennis shoes on and and I went to the mall to get something, and I right on the floor and broke my hip. So, and I knew on the floor when I was waiting for the ambulance that this is going to be when I get into the hospital. I was in the hospital, and they had to, well, I did eventually get taken to Johns Hopkins because I don't think they wanted me there anyway. They would now because they're part of Johns Hopkins. And I had to have, they put pins in it. They pinned my knee with screws and pins. I had a great orthopedic doctor. I had a really great orthopedic doctor there.
And then the first time I met you, you were actually in a wheelchair with your leg stretched out, and you were in your 50s. You had a femur fracture at that time. What happened then?
They put a plate on it. That was on the right, and they put a plate on that.
Do you remember how it happened?
Yes, the pain.
You just had pain, and it was a
pain.
spontaneous fracture.
Yeah, and I kept telling the doctor, the metabolic doctor that I had then, I think you were a fellow.
I was a fellow. Yep, exactly. I was coming. You were
pregnant
bringing.
fellow?
You were bringing a specimen to
Were
me.
you a pregnant fellow?
I might have been. My son just turned 21. That tells you how long ago it was.
So yeah, they put a plate on that, and that's fine. It works fine now. It's still there.
More recently, a couple years ago, you were seeing him in the office, and you were complaining of some pain in your thigh, and we did an X-ray, and we found too that you had a spontaneous fracture that needed rodding.
Yeah.
What about your arms?
Well, I've broken my arms between the two of them 5 times. And when we fall, anybody else gets up, they put a cast on it, and it's fine after 4 weeks. But not when you have XLH. Then they have to do surgery on it. And so I did. You know, the broken arms were slips and falls.
And this was even when you had been on treatment most of this time. And I just put this slide up here to talk about treatment goals when we think about conventional therapy in individuals. And we treat individuals, adults, we restart treatment if they're not on it, or we continue treatment when there's fractures, when there's evidence of osteomalacia, when people are about ready to undergo surgery for a fracture, or if there's a lot of bone and skeletal pain. And so these were reasons that we would treat people with conventional therapy with XLH. But you'd been on conventional therapy and we're still having these fractures.
Yeah.
And
I haven't had any too recently, but I guess they're not old.
we're knocking.
They're not old.
We're knocking. So I also remember the first time I met you when you had that femur fracture, that you were also having a problem with your medications. And can you tell us a little bit about that?
Well, I was having a problem with my medication, but I also had hyperparathyroidism.
Right, so the problem that I remember was that you had been on calcitriol.
Right.
And the level got too high.
The level got too high.
Yeah.
And I do remember that I was playing tennis then. I came home one day and I just went to bed. I was so tired. I was exhausted. And I thought, well, what's wrong with me? So I had to call the doctor and they did a blood test, and oh God, it was so high. My kidneys is what they were really worried about, because my creatinine was way off too.
And I remember you telling me too that ever since that time you had been a little bit lackadaisical about your monitoring, needing to get blood work every 3 months, but after that it was really scared you when your kidneys had begun to fail, and you've had to watch your kidneys very closely ever since then.
Yes.
Yeah, so it was...
So I see a nephrologist 3 times a year.
So you can tell them a little bit about how difficult it is. Dr. Choi is her nephrologist, and I are good friends, but we've become much better friends during treatment with Joanne, because we have to negotiate all the time about treating her for what's going on with her XLH and also protecting her kidneys. So that requires a lot of monitoring of blood, monitoring of urine. So it's been a really fine balance that we've had to achieve, and it's been a lot of negotiating back and forth. And Joanne's in the middle of the negotiation, unfortunately.
Well, it's also, and the parathyroidism was the other problem too.
Yeah.
Because I started getting very tired with that. I couldn't understand what was wrong. And I don't know what causes that, really.
Well, I mean, I think that the treatment certainly has to do with it, but I think that there's probably an underlying propensity for hyperparathyroidism and XLH. I don't think that that's been proven, but I think people with XLH get tertiary, meaning parathyroids, multiple parathyroids that become overactive with treatment. And with you, it was very difficult because we wanted to use calcitriol to heal things like your fractures and to keep you from fracturing. It would often make the blood calcium level go up because the parathyroids make the blood calcium level go up. And so it was a very difficult balance to achieve. And finally, you ended up having parathyroidectomy. And I remember Dr. Tefano calling me while you were on the table trying to decide how much parathyroid tissue to take out.
Well, I couldn't believe that I was only left with a quarter of one.
Yeah, but it's doing its trick.
4 whole ones, and now I only have a quarter of one.
So other than these fractures and then the complications of therapy, what other issues have you had as an adult with XLH?
Well, I really can't think that I have any others except the bone breaking and the...
Do you ever have any problems with stiffness or moving around, mobility?
No, I'm pretty lucky, but I used to do a lot of exercise and Pilates, and that really helps me greatly.
So I just put here, and many of you know this, just some of the complications, and Sonia and Carpenter and Emma will go over this later, but we know that the complications and many of the effects are on the bone, but also on the tendons and on the joints. And enthesopathy is something I heard a lot about yesterday, about this calcifications of the tendons as they insert onto the bone. And this causes a lot of stiffness. It causes a lot of problems with mobility, and especially when you have the longitudinal ligament of the spine involved, there can be compression of the spinal cord. So those are just some of the issues that adults deal with a lot in XLH. So I'm going to skip this treatment because we talked a little bit about your experience with conventional therapy being a very fine balance and being not very effective sometimes.
Yes, there were times when it wasn't very effective, and there will be times, I guess.
Yeah. And so I wanted to talk a little bit about complications of conventional therapy. We talked a little bit about the development of hyperparathyroidism. We've also talked about renal compromise when your blood calcium level goes too high. There's also issues with the calcium being deposited in the kidneys or causing kidney stones. And gratefully, I don't think we've had any problems with that.
No.
So those are something you have to keep track of because of the therapy. So the therapy is great, but what we call the therapeutic window, meaning the range of therapy can be narrow, and so we have to monitor it very, very closely. And a lot of people talked yesterday about GI intolerance of the medication. Do you have any problem with the
No, I
phosphorus?
did when I first went on it when I was young, as a kid.
But now you're
Now
doing
I'm
pretty
fine.
well.
Yeah.
Great. And then this just gives you an idea of the monitoring. Blood work, urine work, I know you all know how to do this, and then occasional ultrasounds of the kidney. So it takes a lot to keep up with conventional therapy. We talked about the subtotal parathyroidectomy. And then this is a question that I heard yesterday that I thought was great, and I wanted to ask you. If you had the opportunity just to wave a wand and alleviate one thing about your XLH, what do you think it would be?
I'd like to be taller.
There you go. I love that. That's great. So what I wanted to do is I just wanted to spend a few minutes here talking about the new therapy for XLH, burosumab, to tell you a little bit about what we can expect in adults and what we've seen in clinical trials in adults. And I'm going to present some data that many of the people here, Dr. Ansonia, Dr. Emmel, Dr. Carpenter, participated in our group as well in doing these burosumab trials. So this is a very complicated slide, but Dr. Ansonia did a great job of orienting us to this yesterday. But basically, what happens in XLH is the problem with the PEX gene results in too much FGF23. And FGF23 has effects on the kidney, and it has effects on vitamin D. The effect on kidney is to keep it from reclaiming phosphorus, which is important for bone mineralization. And the effect on vitamin D is to keep it from making the active form of vitamin D, which is also important for both calcium and phosphorus absorption in the gut and actions on the bone. So it's a double whammy. You end up with low phosphorus in the blood, which means the bone doesn't get enough phosphorus, and you can't make this active form of vitamin D, which is important for phosphorus absorption in the gut. So you end up with hypophosphatemia. What burosumab does is it's an antibody that binds up FGF23 in the blood. So you have too much FGF23, but it binds it up, so it keeps it from having the effect on the kidney. So the kidney then begins to reclaim phosphorus, which then ends up mineralizing the bone. And then it also helps the vitamin D begin to be made again. So you can increase phosphorus absorption in the gut. The benefit of this is you can get the phosphorus into the normal range. And with conventional therapy, it's tough to get the phosphorus in the normal range. And in fact, we discourage doctors from trying to push phosphorus into the normal range because you end up with A, you can't tolerate the medication, and B, you end up with this hyperparathyroidism more quickly. So it's like a seesaw of trying, like Dr. Ansonia said, trying to pour in phosphorus, but you're peeing out the phosphorus, and so it's just like pouring it in a few times a day, and most of the time the phosphorus is low. But with the burosumab, the phosphorus stays in the normal range. So this is the published trial, and you'll see many people on here that you recognize. Basically, it was a trial where we looked at burosumab versus placebo, meaning some people got a placebo shot and some people got the burosumab shot every 4 weeks, and it was 1 milligram per kilogram, so it was based on weight. And then we did that for 24 weeks, and then we let everyone go on burosumab for the following 24 weeks. So it's a 48-week trial. We looked at things like phosphorus and vitamin D, and we looked at urinary phosphorus. We looked at other things like stiffness, patient-reported outcomes of stiffness, patient-reported outcomes of fatigue and pain. So this is the data for the serum phosphorus. And remember, the first 24 weeks, there was a placebo group, meaning people were getting inactive injections and people that were getting burosumab injections. And that lower line is the lower limit of normal for phosphorus. And you can see that in the burosumab group, there was an increase in the serum phosphorus that stayed up during the time of the trial. Those that were on inactive injections and that were crossed over to active injections, their serum phosphorus then went up into the normal range. So what's, I think, really great about this is about 94% of the people on active injections achieved a normal serum phosphorus, and only 7.6% of people on the placebo injections achieved a normal serum phosphorus. And this just shows, too, that it has the expected effect on the vitamin D levels. It has the expected effect on the urine phosphorus levels. Urine phosphorus levels go down, the vitamin D levels go up. And then, as we talked about a little bit yesterday, what was surprising to us in these trials is everyone got a skeletal survey, so x-rays of multiple bones before they got entered into the trial. And we found that about 50% of the people that were in this trial had fractures at baseline, which was surprising. They were fractures that people didn't have pain or weren't aware that they had. What we saw, too, was that there was increased fracture healing in people treated with the burosumab. The majority of people, about 75%, had complete fracture healing by 48 weeks. And the people that were crossed over, where they were on the inactive agent and then crossed over to the active agent, also began to have fracture healing. So this graph shows you that. So here's the percent of fracture healed in the active group that continued through the 48 weeks. The placebo group crossed over to the active treatment, and again, you had improved fracture healing. There was also a survey called a WOMAC survey, which is basically used in arthritis research to talk about stiffness, pain, other indices that people in arthritis experience. And so it's called a WOMAC questionnaire, and that was administered to people. What we found there was that people that were treated with burosumab in the green had an improvement, a statistically significant improvement in their stiffness that then continued out through week 48. And those treated with placebo didn't have any improvement in their stiffness, but then when they crossed over to the burosumab, they had improvement in their stiffness. Also, the WOMAC talks about physical functioning, getting around, and mobility. And again, there was improvement in that physical functioning with the burosumab treatment that then continued through 48 weeks. And again, those on the placebo injections did not have improvement, but then improved after the crossover. It should be told, though, that after we crossed over, people were not blinded to what type of injection they were on. So there could be a little bit of bias in these second 24 weeks. We just need to keep that in mind. And then talking about pain, there was a slight improvement in pain, but it was not statistically significant in those treated with burosumab versus those treated with placebo. But those treated with the placebo injections, when they crossed over to burosumab, then they had a statistically significant improvement in their pain versus baseline. Joanne has done a great job in helping me illustrate that in adults with XLH, they have distinct manifestations versus kids with XLH. There's different things to worry about, and there's different manifestations. And that conventional therapy can address some of the manifestations, but there's often many manifestations that aren't addressed by conventional therapy, and conventional therapy has its challenges. The narrow therapeutic window, she developed hypercalcemia, and she had developed worsening of her kidney function, and also hyperparathyroidism. So there's some limitations to conventional therapy. New treatments, such as burosumab, that target the FGF23 that's excessive in XLH is promising because it can improve hypophosphatemia, it can improve fracture healing. What we don't know is, will this improve enthesopathy? Will this improve some of the bony changes that have happened that are chronic changes? And can we prevent them if people start on this as children? This will be helpful to know, and it's really important. It's a focus of one of the trials that is now opening. That's the XLH disease monitoring program, the XLH DMP, where we're going to look at people that receive burosumab and people on conventional treatment and people on no treatment can enroll in this trial. And we'll be following prospectively, looking forward to see what happens with enthesopathy, what happens with the kidney calcification, what happens with fracture healing, what happens with growth, what happens with all the bowing and the other things that we see in XLH. So we'll be able to look forward and compare people on treatment and people who are not on treatment, just to get a good idea of what is the natural history of XLH. So I think that that's going to be a great opportunity for this community moving forward. With that, I want to thank very much Joanne for being my partner in crime today and for telling her story.